So coming to, do we have data pertaining to this particular device? Yes, we do have a big registry and a study. It's called as a FLASH registry, where they studied almost, I would say, 800 patients enrolled at different sites in States and 200 in Europe. The primary endpoint was basically device-related mortality, major bleeding. And what they found was there was decrease in mean PA by 23%, and other parameters definitely improved. So after this, they went with a study for high-risk patients. Here you can see they followed these patients for 6 months, and there was definitely improvement in normal RV function, dyspnea, and 6-minute walk test. So there was a follow-up of 6 months. Now they did a FLAME study, which was basically for high-risk PE. On the left-hand side, there was a context arm in which other non-FlowTriever therapies were used, like anticoagulation, lytics. And in 53 patients, they used FlowTriever. And they could see like the in-hospital adverse outcomes in which patients in which the FlowTriever was used was very low compared to the context arm. And hence this study was also stopped because of the advantage which was shown with the really high or massive PE. So which patients to treat as of now? So what does the guideline say is, so we are here actually, so any patients with intermediate high risk or really high risk are the patients who qualify for large bore aspiration devices. So because you have seen that high risk, we don't have time, even if they are not a great candidate for surgery. And intermediate high risk, again, they can go into high risk or not responding to or lytics or anticoagulation, can undergo this therapy. And eventually, I think the indications will definitely increase as we get more and more confident. So these are basically ACCC guidelines in which for high-risk PE, they have come out with percutaneous catheter-directed treatment should be considered for patients which are high risk in whom thrombolysis is contraindicated or has failed. So there is nothing against lysis, but if it is failed or contraindicated, definitely go with the device. And in intermediate high-risk PE, as an alternative to rescue thrombolytic therapy, surgical embolectomy, or percutaneous catheter-directed treatment should be considered for patients with hemodynamic deterioration or anticoagulation treatment. So, I mean, same happened with MI. It was basically anticoagulation, lytics, and now we are all towards intervention whenever a patient of MI comes. The similar debate started, I would say, almost a decade ago for stroke. There was fight going on in every hall between neurologists and interventionists, lytic versus mechanical thrombectomy, and now mechanical thrombectomy is the treatment of choice. So the arrow is shifting towards MT, and I hope in future, even for P with the simpler devices coming with our experience, imaging, I think it will again shift towards basically mechanical thrombectomy eventually. And yes, there is need for PERT team because it's not an individual's job. So there has to be a PERT team where it's almost like changing tires in the Ferrari when they come. And every aspect, right from imaging, cardiology, aspiration, post-care is important. So PERT team plays a very important role. So this is just one patient to show you that the patient collapsed in ER when he came, was taken directly to for pulmonary thrombectomy, and in the evening he was sitting and talking very well. So this is our data. Initially, as there was no large bore devices available, even we were skeptical of using any aspiration devices. I got my training in US and I remember using ECOS, pigtails to macerate the clot, and then the CAT8 device came. The results were not promising, so we were also shying away with the interventions, and the only treatment left was lytic with whatever risk of bleeding we used to accept it. Now slowly with the large bore device coming up, and we have started a PERT team in our hospital, so we get a reference, the PERT team is initiated, and then I mean the number of cases has increased in last 2 years, and we have started using large bore aspiration devices. Thank you.